You know, we say that good health is just the slowest rate at which we have the decline. And when we go into the final phase of our lives, the end of life, we begin to notice that our patient or our family member begins to withdraw. And the most common thing that we begin to experience is that their physical activity really declines, and they begin to sleep more, and they begin to eat less, and they get less involved in their activities of daily living and their socialization. So how do we know someone is dying, and how do we diagnose the death and dying is something that is really difficult to predict. And we as doctors, studies show, are only about 38% accurate when it comes to prognosticating. We're very good at diagnosing and treating, but we're very not so good at the prognosis aspect of end-of-life care. And there's really no marker in the blood work. There's really no way that we can see any particular sign or symptom except for this constellation that I mentioned, that a person will become more frail, will not be eating, and begins to withdraw. Patients need to be considered for hospice or end-of-life care, and as a rule, most patients get referred very late during their last stage of life. And it really does the patient and the family a disservice, because there's really a shift of focus that we need to have in the culture of death that we have here in the United States. We need to shift that focus to going back to the home setting, wherever home may be for that patient or loved one. And as I said last week, it is a grassroots effort that started back in the 60s, and then in 1982, the Medicare benefit began to cover the hospice benefit. And we do see now more and more people accessing hospice, and probably 1 out of 4 Americans who die access hospice care. And when they do access hospice care, they can see what a great service it is, because they get a team of professionals to come and see them at the home, and really also focus the care on the goal and expectation of the patient. And that's one of the other things that we do see in this evolution of patient care here in the United States, that it becomes very important to have, we say, the autonomy of the patient, the self-will of the patient. What does he or she want at the end of their life? And we make decisions, we make choices, but when it comes to end-of-life care, it's one of those things that people really freeze up over, and they have a real difficult time discussing. But we do need to bring it out more in the open so that people understand their choices and get this education for end-of-life care. The topic today is going to focus on pain management at the end of life. And pain management is really the cornerstone of what we do in hospice care. We have so many people that die here in the United States that die in severe pain. And it's something that we can really minimize, because we do have that expertise with hospice services. It's a tragedy to see someone that has not had any pain management, that they have an illness, in particular, let's say a patient with cancer that has severe metastases in their bones and or their organs, and they have a very difficult time with pain. And the treatment focus is usually on curative approach, but if we don't adopt a palliative approach, which is, as we said last week, palliative care is focusing really on the symptom of pain or trouble breathing or nausea, whatever the symptom may be, and focusing on the emotional and the spiritual needs of those patients, the patient will suffer. So we do a very good job of really looking at this symptom assessment scale in each individual patient, and then seeing each individual patient's goals and expectations, because those symptoms are the symptoms that really make a difference and impact the quality of life, the impact the quality of life that's remaining. So if we can address that symptom and minimize that symptom, then the quality of life will be improved. And probably one of the biggest fears when we do face the end is pain. And when we have pain, it's by definition, we say pain is whatever the patient says it is, whatever discomfort or distress it is. People don't want to be considered complainers, and it's real difficult to get them to report pain. But we need to report pain just like we report blood pressure or blood sugar. We need to ask patients what is their self-report and get away from the habit of asking, are you complaining of pain? Because people will always want to be very stoic, many times hold back and not report that pain. So number one, we need to ask them on a scale level between 1 and 10 what their pain level is. And we say the level 1, 2, and 3 is mild, 4, 5, and 6 is moderate pain, and 7, 8, 9, and 10 is severe pain. And then the level of pain will help us know specifically what medicine we can use to help their pain. And there's a lot of advances, and there's really wonderful medicines, routes of administration that vary, that we can really get most patients under good control of their pain. When people have pain, we also can divide it into acute pain or chronic pain. Acute pain is anything that lasts several days after an injury, up to maybe a few weeks. But when pain is longer than 6 months, we consider that chronic pain. And one of the biggest mistakes that I see in pain management today is that we don't put people on long-acting opioids or pain medicines to give them the around-the-clock pain relief that they need. And it therefore breeds sort of we call it a pseudo-addiction or a false addiction, because they're asking for pain every 4 hours, and we're under-treating their pain. And there is a difference between addiction in the realm outside of hospice, because when patients come on hospice, we have a very short time to live, and addiction should not be an issue. And studies show actually that it's probably less than 1% of patients that come on hospice that have problems with addiction of their pain medicines. And it's one of those big barriers that we always have to try to cross, and we have to feel comfortable as physicians and nurses and caregivers to be able to make the patient comfortable to take the pain medicine and not let them suffer needlessly. And it's a huge issue. I think morphine, and we call it opiophobia, being phobic or fearful of opioids is one of the biggest barriers to effective pain management. In the past, the fear was great for addiction, and for really it was underutilized, and then it swung the other way. And I think there are a lot of cases where people are addicted to opioids today. But when we look at the hospice field, the end-of-life field, addiction should not be an issue. We need to really relax about that and not really get uptight, because when we do, the patient suffers. And we do need to be more liberal, because they do have conditions that are very painful. And we classify pain, as I said, into acute and chronic pain. Most of the patients that come on hospice do have chronic pain. And then we also classify pain as somatic, or your body, your muscles, your bones, your joints. That's called somatic pain. And then we classify it into visceral pain, the viscera or the internal organs. And we can start with the brain, the lungs, the heart, the liver, the pancreas, and then you move on down, the intestines, the pelvic area. Those are the visceral organs that can give you pain. And then you have the nerve pain, starting with the brain and the nerve endings that come from the brain, the spinal cord, and the nerve endings. Of those 3 types of pain, the somatic pain is probably the easiest to treat, followed by the visceral pain, and the nerve pain is the hardest to treat. And the other important concept with pain management is that you have to think about the total pain of the patient. And by total pain, you're adding up not only the body, but you're also adding the emotional and the spiritual realm of possibilities. So when I visit a patient, and I had a patient one time that had a pain level that he said was a 20. But when we did more interviewing, it turned out that he had been estranged from his family. He was a military officer who was living alone, and he had a tremendous amount of loneliness, and he was facing the end of life without having his family call. And when we began our team approach of helping him, we didn't have to put him on morphine. What he needed was emotional help, and having people surround him so he wouldn't feel so lonely. And I think this is really important with hospice. People form these relationships that are wonderful with the nurse and the caregiver or the patient. Yesterday, seeing one of the patients in one of the assisted living facilities with a husband and wife, the wife being the patient, the husband said, "I want you to guarantee me, Dr. Cisneros, that you don't, that I love your nurse, Deborah, and I want to make sure I keep Deborah to the very end. I just think that she's wonderful, and your nurse's aide that comes and bathes my wife is wonderful." And it makes such a difference, that relationship, that you can't really quantify. It's one of those things that you can't put on a chart, but when you help people emotionally this way, it reduces their pain level, and it reduces their breathing trouble, or it reduces their symptom, whatever the symptom may be. Because studies do show when people are alone, when they're anxious and they're fearful, if they don't have an answer and they don't have a person, you have that human element lost, it really multiplies the pain. And the pain can be very emotional. So the total pain concept is something that's really huge. We don't want to just say that a person that has a pain level of a 10 gets morphine if we discover that pain is really emotional or spiritual pain. But if they describe the pain with an adjective that's really on par with physical pain, they say the pain is really sharp, throbbing, achy, burning, pressing. That's an adjective of really physical pain. And we need to go there, and we need to treat it. If it is a 10, we need to treat it with the appropriate pain medicine that would be for severe pain. If the patient would describe that the pain was killing him, that it was torturing him or her, that they felt punishment with this pain, that will also be examples that you would hear that this may be spiritual pain. And then you need to tease those three components, because our bodies are body, soul, and spirit. I think most of us, we were saying last week, we see all religious viewpoints and we see patients that are atheists, we see patients that are agnostics, we see patients that have many different faith systems that they lean on at the end of life. But primarily, the majority of patients do understand that the body and the soul are, entwined, and when death occurs, it's a separation of the soul from the body. In the body, the minute the soul leaves the body, that's death. And so the soul is that part that you can't really, you don't have any fibers for the soul. It's what runs this body of ours. And the soul, we say, is the emotion, the will, the intelligence of a person. And the spirit is that part that we say connects to God. And that God, of course, gets housed in this temple or this body. So it's a very interesting thing to see when people do approach the end of life, and how it begins to activate that spiritual sense. And it begins to activate also your emotional sense. So when you suffer physically, it creates these other effects on who we are as human beings, and vice versa. If you suffer spiritually or emotionally, it begins to affect the body. So total pain is very important. We have social workers, we have chaplains. We of course use the community or the parish or the church that the patient is going to, or the synagogue. They will go ahead and continue to see them, but we're just ancillary, and we can be there if they have no one. So we can kind of discuss these issues and help them through their grief, because they're beginning to experience or anticipate this grief, this loss that this illness is going to create. So we use medicines that help people with depression, with anxiety, and a lot of it is just that human relationship part to help them know that someone there is there for them and cares for them. And I think hospice does a really wonderful job of helping patients and families concerning this. The pain management is, as I said, it's the definition of self-reporting whatever he or she states it is. We have to believe as physicians and caregivers that if a patient is in pain, it's a warning signal. Something's going on. Like we were saying, it could be like the light in the engine of your car. I have my light on right now. I have to take it to the car dealer later, and it's there, and I need to take it in to get a checkup. The same thing happens with your pain signal. When you have a pain signal, if it's physical pain, it'll describe it in those certain terms that I mentioned, and then we go through a pain assessment, and then we treat, and then we reassess to see that the treatment has been effective. And if it has been effective, then we continue that treatment. But the initial period of time when we evaluate the patient is to first assess the patient and see, is it mild, moderate, or severe pain, and then use the medication for mild, moderate, or severe pain. The medicine that we use for mild pain is primarily Tylenol, although you can use aspirin or you can use the non-steroidals that are like Motrin, Advil, Nuprin, Naproxen. There's many non-steroidals, and those would be classified for mild pain, and each one of them has its own particular side effects. And if you've seen the literature recently, the Tylenol has been lowered, the Tylenol total dose. Adults that are less than 65 years of age, we recommend a total of 4,000 milligrams of Tylenol a day. If we go beyond that, then the risk of liver injury becomes greater. And they're beginning to combine now the hydrocodone with 325 milligrams of Tylenol so that people don't get too much Tylenol in their medication. And so Tylenol is a very good pain medicine for mild pain. I think that's probably the one we use the most for hospice patients. But most patients on hospice have more than mild pain. They have moderate to severe pain. The moderate to severe pain drug of choice with hospice is hydrocodone. Hydrocodone is, we would say, Vicodin or Lortab, are the two most popular ones that we use, or Norco. And they have hydrocodone combined with Tylenol, with 325 milligrams of Tylenol. The moderate pain patients that use these drugs, we have to remember that they're only short-acting. They only last 4 hours. So if you give someone hydrocodone with Tylenol and they have chronic pain and it's moderate to severe, they're going to be needing a long-acting so that we don't undertreat. And when you have pain around the clock, shouldn't your pain medicine be around the clock also? But if it's acute, moderate pain, it makes sense to just use a short-acting medicine. You don't need a long-acting if it's just going to be there a few days. But if it's there weeks or months, and it's been there many times years, and you have moderate to severe pain, you need to consider a long-acting opioid that will be in the class of morphine. And one of the things that I think really reduces the barrier for using morphine, because when I mention the word hospice, the letter H, or morphine, the letter M, people really get very frightful, or they get this fear that they don't want to take morphine, they don't want to come on hospice. And we say, well, with hospice, it's really not about, we're not about death. We want to give people the remaining time to live as long as possible and give them hope. You know, the H is more for the hope and for the quality of life. And for the morphine, morphine is a very, very good pain medicine that's a gold standard for moderate to severe pain. And there's formulations of morphine that are long-acting, that it can be given every 12 hours or once a day or every 3 days as a pain patch. And they give you around-the-clock levels of those medicines in your system so that you can have pain relief and you don't have the fluctuations. And one of the more important principles of pain management is that if you can help the person sleep well, you know, then the pain during the day will not be as severe. But if you don't sleep well at night, you know that then your pain tolerance will really be lowered and you're going to go into pain much easier. So we recommend morphine at a low dose to begin with, and the hydrocodone or codeine, let's say as an example, codeine, hydrocodone, have the same equal analgesic potency. 1 milligram of hydrocodone is 1 milligram of morphine. And I think this is something that really helps everyone understand that if you take 5 milligrams of hydrocodone, it's the same as taking 5 milligrams of morphine. Morphine is not 10 times stronger than hydrocodone. So if you have taken a Tylenol number 3, and most people have, you know, having had, let's say, a tooth abscess or a kidney stone or orthopedic procedure problem, you'll get a prescription for Vicodin or Lortab, and people will take Vicodin or Lortab and maybe at 5 milligrams every 4 hours, and they don't think twice about it. But if you give them 5 milligrams of morphine, they really shun the taking of morphine just by the name that morphine has. So morphine is not dynamite compared to hydrocodone, but the advantage is that because it's not complex with Tylenol, it does not have a ceiling. You can go up on the morphine as high as you need to because it doesn't have a total dose of Tylenol that limits the amount of morphine that you can take. So the moderate pain, to review, are short-acting opioids, call them SAOs, and those are the hydrocodone. And then for the long-acting opioids for severe pain, we have several choices, and I want to review this briefly with you. You have morphine, you have methadone, oxycodone, OxyContin, fentanyl, which is a Duragesic patch, pain patch, and you have Dilaudid. And these are the pain medicines for severe pain that we use often. And before I start reviewing these, Demerol and Darvocet are not good pain medicines for chronic pain. And in fact, Darvocet was taken off the market, and a lot of people had been using Darvocet. But there are reported cases of severe toxicity and not good pain relief with Darvocet. And so it was taken off the market, and Demerol is still used in the hospitals, but it is not a medicine that we ever want to use for chronic pain because there's a high risk of seizures with Demerol. People use it in the hospitals, but we're trying to get away from Demerol and going to morphine actually for severe pain. Or morphine or Dilaudid are probably the most common drugs that we use in the hospital that can be given intravenously for severe pain. Morphine, as I said, is a gold standard. It's a natural occurring medicine, just like codeine. They come from the same plant, the opium plant. And the morphine has been around for centuries, especially for dysentery and for pain. It causes constipation, and that's one of the reasons it was very useful for dysentery. And when people do take opioids, invariably you will have constipation. So if you take an opioid for pain, you better be on a laxative. And the best laxative to take that doesn't cause cramping is the Senecot. There's many products that have Senna, but if you get on a pain medicine, even for the moderate pain, the hydrocodone or morphine, you better combine it with a laxative so that you can not, otherwise, if you have constipation, the constipation will be worse than your pain, and then you won't want to take the pain medicine anymore. So we really advise strongly all our patients on hospice, we automatically write a prescription for Senecot. Usually 2 tablets at night and then maybe 2 tablets in the morning, and you can take up to 8 tablets a day of Senecot to help the constipation that these medicines produce. And the next side effect of morphine is that it does cause sleepiness or sedation. That can be a good thing when you're having uncontrolled pain and then your pain gets controlled. You're going to have time to catch up with your sleep. And when you catch up with your sleep, you're going to get some rest. And rest will be good for you, for your pain. So constipation, sedation, and then there's a fear of respiratory depression that people worry about. Respiratory depression, if you properly use the morphine, is not an issue. And pain medicine, hydrocodone included, and morphine is very effective for shortness of breath. We use a lot of it for shortness of breath for people that have pulmonary or cardiac conditions that cause them to be short of breath at the end of life. So it's multifaceted. When you use morphine, it's not only for pain, but the other twin, which is just as important, is trouble breathing. Morphine or hydrocodone do a very good job of reducing the anxiety of that air hunger that people have at the end of life. Morphine, as I said, gets titrated like all these medicines do. If you've never taken a pain medicine, we recommend that we start at 5 milligrams, just like a Vicodin. We start with 5 milligrams. And the way you titrate it is that if you get no pain relief with 5, you have to go up 100%, which is 10. And if 10 doesn't help at all, then you go up 100%, which is 20. We do find that most patients within 5 to 20 milligrams of morphine, they do get relief. If you have someone that is not getting relief, what we tell our nurses, instruct everyone to understand, is that they may be having spiritual pain or they may be having emotional pain. If you keep going up on your opioids and it's not helping, think of those things. It may be that, and it may be nerve pain. Nerve pain is the most difficult pain to control, and you may need to use some adjuncts, which are helpers that really attack the nerve pain, because the somatic pain and the visceral pain can get improvement, but you may not have it with the nerve pain. So morphine titrated properly is very safe. And as I said, if we're comfortable in using it and we do the education for the family and the patient, they'll feel comfortable in using it so that they don't suffer with these distressing symptoms at the end of life. The next drug is OxyContin or oxycodone. It's 1.5 times stronger than morphine. It hits different pain receptors, and it may help better some people with their pain than morphine. When you try an opioid and you're not getting success with it, and you've ruled out the other things, spiritual issues, emotional issues, nerve pain, then you have to think about rotating the opioid and switching. You don't want to switch real quickly. You want to titrate and kind of maximize your drug dosage. But if you're not getting relief, then you have the luxury of being able to rotate, and that rotation is helpful many times because it does attack different pain receptors, because each drug is a little bit different, chemically speaking, and therefore it helps with different pain receptors, and it may help that person's pain. Methadone, I've had a lot of experience using methadone. It's a very good pain medicine. A lot of people, of course, equate methadone with addiction to heroin. People that have that heroin addiction use methadone. But as a pain reliever, especially for nerve pain, it has done some miraculous improvements in people's nerve pain conditions. And I've had patients that have had severe pain for a year or longer with cancer, and they hadn't tried methadone. And when we put them on methadone for the nerve pain, it has a tremendous improvement that the patient notices. So methadone is really good to have there as a choice for certain specific types of patients and their pain. OxyContin has gotten a lot of bad press. Like a lot of the opioids, OxyContin has been abused a lot. But going back again with hospice patients, we're in a totally different territory here. It is very important. It's another very good drug. It's a little bit more potent than morphine, and a little different than morphine. And it's chemically derived. It's synthetically derived. It's not a naturally occurring opioid. Neither is methadone. Methadone was engineered during World War II in Germany. And then fentanyl is a patch, a pain patch, that you wear every 3 days on your skin above your waistline. And it has certain applications. The primary setback of fentanyl patches is that they're so expensive. They're very, very expensive and sometimes cost prohibitive. But if you have someone that can't swallow, and you need to have a access of a delivery system other than the oral route, the fentanyl patch is a really wonderful choice where you can have very good pain relief through this fentanyl patch. And it's amazing because one patch at the starting dose of 25 micrograms is about the equivalent of 60 milligrams of morphine. And patients and families don't hesitate with a pain patch because the name is not morphine, but you are getting a pretty strong delivery system of morphine through the skin. It's just not called morphine, but it is a strong opioid for those patients that have trouble swallowing as a choice. The downside also is that if a person's very cachectic and they don't have enough sub-Q tissue, the patch may not be reliably absorbed. You need to have a little bit of subcutaneous tissue. And the other downside is that if you have a fever, it absorbs the medicine through the skin very rapidly, and we recommend that the patch be taken off if a person develops a temperature. Or if they go into a hot tub, we've had some patients that have had fatalities because it gets absorbed so quickly. So you don't want to put anything hot over that patch because the medicine will just go into your system like an intravenous shot. It'll go in there too quickly. So there's some cautions with the fentanyl patch that we need to be aware of. And then Dilaudid is a wonderful drug for pain. It has helped many patients that I've seen over the years, especially in the hospital when we use it intravenously. It also comes orally, but it only comes in a short-acting form. And it is a drug of choice if someone has kidney failure because it does not build up metabolites like morphine does with kidney failure. When your kidneys fail, the metabolites can build up, and those metabolites can make people get a little jumpy. It makes the nervous system get what we call these myoclonic jerks because it stimulates the nervous system, and the nerves have that jerk of the muscle, and it's like when we are falling asleep and you get that little convulsion sometimes before you fall asleep. People that get pain medicine, often it's one of those side effects that we see commonly, and the treatment for that is to lower your pain medicine and to maybe flush out the pain medicine by giving the person more fluid so they can try to flush it out through the kidneys, and then give them a little bit of a anxiolytic like Ativan to reduce the jumpiness of the nervous system. But Dilaudid is very well tolerated. It's one of those that we'll rotate to when people are getting those myoclonic jerks with morphine, and it gives people good pain relief. So it's a good choice. Let's see, we have some questions here, I think, that are coming in. If I want hospice for my family member, who do I contact? Will my doctor tell me who to call? And this is what we had addressed last week. You know, the physician has to make the referral, and then you need two physicians. The second one will be the medical director of the hospice. Would go ahead and then certify that the person is appropriate for hospice care, that they have we call it a terminal condition. If the disease or condition were to run its normal course, that the physician would say in his estimate or her estimate that it would be 6 months of life or less. But there's many people that live longer than 6 months, and as you know, physicians don't have a crystal ball. There's no way for us to know how long, but we do need a referral from a primary care physician or a specialist, as long as the person is a physician. Who makes the decisions for the person in hospice care? It generally becomes the medical director's job to follow the patient 95% of the time, but your physician can stay involved, and they can manage the entire course of treatment while your loved one is on hospice care. You have to discuss that with your primary care doctor and see that the primary care doctor is comfortable with pain management and symptom management. And many times it's also a joint, they co-pilot or we co-pilot them depending on what they prefer. They may be the first physician to be the first person to call, or they may say, call me, but if we can't get in touch with me, call the medical director. So that's very flexible, and it's really up to the family and the patient to make those decisions. Let's see, what can I do if my mother won't tell me if she's in pain? That's an excellent question. If I think she's in pain, but she keeps saying no, she never, there's the word complains. You know, there's some people that I've seen to the very end with severe, I saw a lady, an elderly lady, that had gangrene, and you could tell that she was in pain. I mean, it's a very painful condition, and her foot was black. I mean, it was, and we couldn't operate, and we could only keep her comfortable, but she did not want to take pain medicine. And as long as someone's alert and conscious and they can make decisions, we can't force them. That's the exception. Most people would say, please help me. And when they're not able to make a decision, and they have dementia, as an example, they have Alzheimer's, if they are frowning and moaning and obviously in pain, they're tense and they're guarding when you move them, you know, they will be treated with moderate to the more severe pain, because it's really, you know, it's inhumane to let someone just suffer like that without treating them. So we go by the physical signs and symptoms when they can't communicate, and we have a lot of patients on hospice under these same circumstances. So that's an excellent question, and that's something that you need to go ahead and be very proactive. And if hopefully if you're with a hospice that's not treating your pain properly, and you feel like they're not really titrating the pain medicine to get the pain under control, call the supervisor for the hospice. And if you can't get in touch with the supervisor, call the general manager or the medical director. You know, because as I said earlier, pain is really the cornerstone of what we do. And if we don't do a good job of treating pain, we really shouldn't be doing what we do. And I would say, granted, there's studies that show there's about a 7% chance that any symptom may not be well controlled at the end of life, 7%. But most of the people will be controlled. There's only like a 7% chance that we say it's intractable. And those intractable patients may be those patients that have severe emotional, spiritual pain or nerve pain that you use all the modalities and you may not be able to get it under control. The next question is on the subject of constipation. When someone gets lots of pain medication, they seem to suffer from constipation. How does hospice handle this? And that's really to get ahead of it. Just like with pain, we say with pain, if you have a little bit of pain, it's like a small fire. But if you let the fire get out of control, it becomes a lot harder. It takes a lot more medicine to get it under control. Likewise with constipation. If someone has constipation and we don't start to preemptively place them on Senecot, plus a stool softener, plus, I mean, we can use many different types of laxatives. The only thing is that we're limited by taking so many pills and things. You have to consider all these oral medicines will cause constipation. The patch, less so. And then there are some other treatments that we don't have time to go over today, but there's other things that discussing with your medical director, and looking at that particular history of that patient, you can make a good regimen, a good bowel program to limit that. The next question, does Texas allow use of marijuana for hospice patients? No, yes and no. I mean, they're for appetite stimulation, THC pills are legal, but not marijuana, not in Texas. And we don't have any experience with the cannabis, I guess the natural occurring cannabis in Texas. Does hospice cover the cost of medications? Yes, it does. And it covers not only that, but the hospital bed, any equipment, oxygen, all the incontinence supplies, and things that just for the hygiene, the shampoo and soap, and things of that nature. Hospice really gives a lot of help for those loved ones with all these expenses. The next question is, withholding nutrition and water at any time when someone is dying seems cruel. How does it feel to the person who is dying? Excuse me, let me get some water. as we go through this question of water, it's very important. Good timing. Nutrition and water is essential for life. But we do need to remember that the person's not dying because they are not eating, but they're not eating because they are dying. That's when a person begins to die, they don't eat, so they lose their appetite, and the appetite is comfort. Whenever someone eats by mouth, it is comfort, but when it's given artificially, by definition, if it's not in the oral cavity, it's not comforting to the person. The same goes for water. If it's not in your mouth, it's not comforting if you give it through an IV. So all the death and dying of all the disease types eventually will have a degree, we say, of starvation and dehydration. But what we really need to focus on is not starvation, dehydration, but hunger and thirst. And we do focus on hunger and thirst, not on starvation and dehydration, because the dying process is that the person stops eating, and that's what we need to consider always. Can someone who is unconscious be in pain? How do you know? I guess we don't know. We don't know, but we assume always, and we want to give the benefit of the doubt, that if someone is unconscious, especially with their body language, when they look like they're frowning and they're just very tense, their body language shows that they're not comfortable. And many times I've heard also that they say mom or dad doesn't look like himself or herself because their expressions are very different. They're very tense. And then when you treat them and they relax, their facial expression goes back, and now they recognize mom or dad, and they say they were in pain. So we don't know, but we treat aggressively, liberally for pain, because we don't want to miss those patients that aren't able to communicate. The next question, how do you help someone at the end of life to avoid the feeling that they can't breathe? About 80% of people that come to the end of life do develop what we call the death rattle. People get congested in their chest. And a lot of those people that get that death rattle have been people that have been fed or hydrated, artificially. And because a normal way that the body goes through the dying process is that they stop eating and drinking. They don't stop drinking completely, but they stop eating first, and then they have very little water. That prevents that congestion because the body begins to dry up. But when you do have the person approaching the end, you begin to see that it's just a very, very important thing to look at them as we see these things and just give them what makes them comfortable. Give them what makes them comfortable, and it's just a little bit of water that makes them comfortable. Most people will not want to eat anymore, but it's really the hardest thing for families and loved ones to accept. But as I said earlier, it's not. They're not eating because they're just going through the dying process. And if we feed them artificially, it doesn't stop the dying process. This is the subject, social workers. What do social workers do for the patients and families? They do a lot. They do a lot, and they help the family with all the resources at hand in the community. We really access, we had a patient just a couple of days ago that I went to see that was unemployed for 2 years related to a brain cancer, 53-year-old, my age, and with a wife of 30 years and a son and a daughter-in-law and a 2-year-old. And that household was just depending on the son's income. And we got a lot of help yesterday with groceries and things because from the Christian community, we just kind of made calls and got people to come over. And now we're getting like a wave of different people that are coming out and bringing groceries or bringing money to them. And with the help of the social worker, the help of the team, it really has made a big impact. I talked to one of the volunteers yesterday that went to deliver groceries, and it was very touching because he had family from Mexico that were coming in, but they didn't have anything to feed the family. They didn't have any food for themselves. So it's a lot of these situations where you see people disabled at a young age that are not able to work, and they're really in dire straits. And the social worker accesses all these community things to get everybody to kind of bring in the troops and see what's out there. And I think social workers are just so important. As I said, hospice is about a grassroots type of model of care, and it was primarily started by social workers and chaplains. Is there an agency that I can contact to find out which hospice company is the best? What should I look for to find a great one? Excellence is always important for all of us, that do hospice. And I think, we have excellence. It's a reputation in the community of the hospice that you're looking for. The people that have the experience, the time that they've been doing hospice work, I think does matter a lot. And it's just word of mouth, in the community, finding out what hospice really provides good, outstanding hospice. And then tell them that's the expectation you're looking for. You do want to find the best, and you want to find someone not only during the admission process that they come quickly, but then the follow-up. How often is your loved one going to be visited, and are they going to get that follow-up consistently? if it continues for weeks or months after the enrollment. Why can't I not contact you directly if I want hospice? You can contact the hospice directly, and then we can help you find the physician that would agree basically with your assessment, because families will hold back and let the physician make the referral, but the physician many times is afraid to make the referral because it will bring a lot of tension in that conversation of end of life. But if you can tell the physician, hey, I watched this program and I think my family member qualifies, the physician will, I think, be usually very, very happy to hear that the family does want this model of care for their loved one at the end of life, and that you do want to do the advance directives, and that you do want them to have the final setting of death, maybe in the home, wherever home may be for your loved one. The subject question is, does hospice help with setting up funeral arrangements? Yes, definitely. That's where the social worker and the chaplain really help us with the community to help prepare the family to get all those things ready. The subject for the next question is pain. My father-in-law is at the end stage of lung cancer. He looks frail, and I am hesitant for my 8 and 10-year-old to see him. I know that death is a part of life, but I'm not sure I should expose him to this. What do you think? Well, I think, children, the more we expose them to the reality of death and the time that is so beautiful, actually, when we love our loved ones, when the end is coming, it's all good for the children. I think it hurts them, and I think with the bereavement counselors, you just need to not force your children, but you can't keep them away from their loved ones. And I think this way they grow up and they can see just what life is about, that we say life is so precious that it's just a vapor, that we don't have any guarantee, any of us, and it's just a beautiful thing when you see kids and you see how they respond, and I think personally, my mom passed away about a month ago, just in early January, and my niece, who's 10 years old, she went to the intensive care unit, and she wanted to go and sing for her. But when she got there, she got too tearful and she couldn't sing, because she always loved hearing her sing. A beautiful voice, and she sang during the eulogy. She sang Amazing Grace, and it was just beautiful. She put the song she was going to sing for my mom in the casket, and she was very involved. I mean, she was a 10-year-old that was very mature, and I think it just helps these families so much. So you need to know your children, and you just do what is in their best interest. And I think most of the time it is better not to isolate them, from death. It's part of life. Last week you said sometimes people graduate from hospice. If someone does not die, do families have to pay back money? No, they don't. The benefit is covered with Medicare and Medicaid alike, 100%. Most health plans or insurance plans also cover the benefit. Most of the patients we have are Medicare patients, so there's never a co-payment, there's never any out-of-pocket expenses for people that join the hospice program. This is a question on morphine. Does morphine compromise lung function? And the answer to that is no. At the proper dose, starting low and titrating or advancing, escalating the morphine to symptom relief, it really does not compromise lung function. And there is a lot of, we say, fear using opioids with people that have COPD. But we use morphine with people with COPD, pulmonary fibrosis, etc., lung disease, for their shortness of breath, and it's very effective.